In completing the occupational profile, I interview a 52 years old female with history of a generalized anxiety disorder and episodic depression. The primary concern includes decreased structure in daily routine, reduced social participation, irregular sleep, and decreased motivation for leisure activities. Although she remains independent in ADLs and unemployed part-time, her occupational performance has declined in consistency, particularly in IADLs and social engagement. She identified feeling overwhelmed and lacking purpose compared to earlier years when she maintained structured routines and meaningful social roles. In the interview, I used informal screening questions to explore mood frustrations, sleep quality, anxiety triggers, and overall occupational balance. These areas were important because disruption in sleep, avoidance behaviors, and imbalance in daily routines are often early indicators of declining occupational performance. Using conventional screening allows me to gather insight while maintaining rapport and avoiding a purely symptoms-focused approach. If she were my patient, I will incorporate standardized assessment to establish objective baseline data. I will begin with the COPM to identify client prioritized occupational concerns and measure perceived performance and satisfaction. To quantify symptom severity, I will administer the PHQ-9 for depression and the GAD-7 for anxiety. I will also use the role checklist to examine change in value roles and the occupational self-assessment to explore perceived competence and value related to daily activities. Together, these tools will provide both symptom-based and occupational-based data to guide holistic, client-centered intervention planning. Her routines have become significantly less structured over the past 5 to 7 years, particularly after transitioning to remote work. She describes increased social withdrawals and disrupts sleep patterns. She reports frustration in mood, particularly during high-stress work period or winter month. However, she's able to identify helpful strength strategies such as walking outdoors, attending to church, journaling, and maintaining a schedule phone calls with friends. These demonstrate insights and self-awareness, which are strong prognostic indicators. Severe social and environmental factors significantly influence her well-being. Protective factors include her spiritual community and supportive friendship, which provide emotional support, accountability, and a sense of belonging. Historically, her structured in-person work environments also support occupational balance by giving her consistent time anchors, social interaction, and clear role expectations. Currently, barriers include working from home, living alone, and increased digital screen time. Remote work reduces external structure and requires high self-initiation. Living alone decreases natural social engagement, and excessive screen use contribute to sedentary behavior and disrupts of sleep patterns. From a PEO perspective, there is a misalignment between person factor, specifically anxiety and environmental isolation, and occupational demands that require sustaining attention and self-direction. This mismatch reduces performance and satisfaction. From a MOHO perspective, there is disruption in habituation, particularly daily routines, and some declines in volition. However, personal causation remains intact as she demonstrates insight and motivation for change, indicating a strong potential for occupational restoration. Some of the occupational challenges that the patient is facing right now will be poor routine maintenance, reduced leisure engagement, anxiety-driven avoidance, and social isolation. As an occupational therapist, I will focus on habit formation and structured scheduling, graded re-engagement in meaningful roles, environmental modifications, workspace boundaries, and energy conservation. Evidence-based interventions will be appropriate for this client will be: first, I will use behavioral activation to address avoidance and reduce engagement. Instead of waiting for motivation to improve, we will intentionally schedule small, meaningful activities, such as short walks or attending one church event, and gradually increase participation. We will also track how her mood shifts after activity engagement. This helps break the cycle of isolation and low reinforcements after scene in anxiety and depression. From a theoretical standpoint, this support MOHO by restoring volition and rebuilding habits while also aligning with CBT principles. Secondly, I will incorporate lifestyle redesign based approach to rebuild daily structures. This will include developing consistent morning and evening routines, improving sleep hygiene, and promoting occupational balance across work, rest, and leisure. From a PEO perspective, this modifies environmental structure to better support her needs. And from an occupational adaptation lens, it strengthens her adaptive capacity. Both interventions build on her strength in insight, communication, and spirituality, while restoring stability and occupational identity. Ethical and cultural competency considerations are essential when planning interventions. Respecting her autonomy and self-determination is a priority. Ensuring she remains actively involved in goal settings and decision making. Maintaining confidentiality is critical, particularly when discussing sensitive topics like anxiety and social isolation. A trauma-informed approach is important to promote psychological safety, empowerment, and non-judgment. Cultural sensitivity is specifically relevant regarding her spirituality, as it is a core part of her identity and shall be integrated respectfully into interventions. Additionally, I must avoid pathologizing normal life stressors, such as adjusting to remote work, remaining aware of my own biases, particularly around productivity and routine, helps ensure that interventions remain truly client-centered and aligned with her value rather than my own assumptions. Additional stakeholders may include her primary care provider, a mental health counselor, supportive family members with her consent, and a trusted church or community leader. Collaborating with these individuals will promote coordinated holistic care that supports both her mental and occupational participation. During the interview, I intentionally focused on therapeutic use of self by practicing active listening, asking open-ended questions, and using reflective statements to validate her experience. I'm maintaining a calm, non-judgmental tone to create psychological safety and encourage honest discussion. I also noticed moments where I felt the urge to immediately problem solve or offer solutions. However, I consciously directed myself to stay present and client-centered. This allows her space to share her perspective fully and ensure that the conversation remains guided by her priorities rather than my assumptions. The most significant lesson was recognizing how loss of a structure can gradually impact mental health and occupational identity. Mental illness does not always present as dynamic, dramatic dysfunction. It often presents as a slow disengagement from meaningful occupation. This insight reinforced the importance of early OT interventions, routine restorations, and viewing occupational participation as mental health stabilizers. It shaped my practice by reminding me to prioritize habits and routine, listen deeply before interviewing, and the most important, recognizing strengths even in vulnerability.